Welcome back to the podcast, everyone. Dr. Khan here, and I am fired up today. We are diving into the upper limb, but specifically one of those aha moments in the clinic. You see a patient walk in, they turn around, and it looks like they have a literal wing sprouting out of their back. We are talking about the long thoracic nerve and the serratus anterior.
It is a classic presentation, Dr. Khan. For our students and residents listening, this is a quintessential board exam topic because the anatomy is so distinct. Before we get into the winging, we have to nail the origin. The long thoracic nerve arises from the roots of the brachial plexus, specifically C5, C6, and C7.
And I love the mnemonic for that. C5, C6, C7. Keep the wings to heaven. It is simple, but it sticks. But Sarah, why does this matter clinically? Why do we care about these specific roots?
It matters because unlike most nerves that form from the trunks or cords, this one comes straight off the roots. That makes it vulnerable very early on. If you see a high neck injury or a heavy traction injury where the head and shoulder are pulled apart, those roots are at risk. On the exam, they will often ask you to identify the nerve based on those three specific levels.
Right, and once that nerve leaves the neck, it takes a bit of a dangerous path. It runs right down the superficial surface of the serratus anterior muscle along the lateral chest wall. Think of it like a wire running on the outside of a house rather than being tucked behind the drywall. It's exposed. Why is that a clinical nightmare, Sarah?
Because of its superficial position, it is incredibly susceptible to trauma and, more commonly, surgical error. The classic high-yield scenario is a patient who has just undergone a radical mastectomy or an axillary lymph node dissection. If the surgeon isn't careful while clearing out those nodes, that exposed wire gets snipped.
Exactly. I tell my residents, respect the lateral chest wall. If you damage that nerve, you have effectively paralyzed the serratus anterior. Now, let's talk about that muscle. It's known as the boxer's muscle. Think of a boxer throwing a punch. They aren't just moving their arm, they are protracting their shoulder blade forward around the ribcage. That is the serratus anterior at work.
To be precise for the boards, the serratus anterior arises from the outer surfaces of the upper 8 or 9 ribs and inserts along the entire medial border of the scapula. Its primary job is to hold that scapula flat against the posterior thoracic wall. It's the anchor. When it's working, the scapula moves smoothly. When it's gone, total instability.
It's like a guy wire on a tent. If the wire snaps, the tent pole doesn't just fall, it pokes out through the fabric. That is what the winged scapula is. When the patient tries to push against something, the medial border of the scapula pokes straight out toward the skin because the serratus isn't there to pull it tight against the ribs. Sarah, how do we actually test this in the exam room?
The classic test is to have the patient stand in front of a wall and perform a wall push-up. Ask them to push against the wall with both hands. If the long thoracic nerve is damaged, the medial border and the inferior angle of the scapula will immediately protrude posteriorly. It is unmistakable. You will also see difficulty in abducting the arm above the horizontal plane because the serratus is needed to rotate the scapula upward.
That is a huge point. A lot of students think abduction is just the deltoid and supraspinatus, but once you get past that 90-degree mark, you need the scapula to rotate to get the arm higher. No serratus anterior, no overhead reaching. Imagine not being able to reach the top shelf in your kitchen. Why does this matter clinically? Because it's a massive functional deficit.
And for the STEP exams, they love to contrast this with other nerve injuries. They might ask about a dropped shoulder, which would be the trapezius and the spinal accessory nerve, but the winged scapula is the calling card of the long thoracic nerve. If you see medial border protrusion and mastectomy history in a question stem, you should be circling long thoracic nerve before you even finish reading. It's all about that history. You see a patient who can't reach their hair to brush it after a chest surgery and you perform that wall test. If you can catch this early and advocate for the right physical therapy or surgical consult, you will truly be their doctor of choice because you understood the functional anatomy while others were just looking at the skin incision. Well said. It really comes down to the relationship between the nerve's path and the muscle's pull. If the anchor fails, the wing appears. All right, let's wrap this up for the listeners. What are the 3 things they absolutely must take to the clinic or the exam hall tomorrow? Number 1, the long thoracic nerve comes from roots C5, C6, and C7. Number 2, it is superficial and commonly injured during axillary surgeries like mastectomies. And number 3, paralysis of the serratus anterior causes the medial border of the scapula to wing out, especially when pushing against resistance. Perfect. Remember, folks, anatomy isn't just a list of names. It's the map of how our patients move. Thanks for joining us today.